Okay, so for the sake of time, let's try to start. Welcome everyone to this paper session on medical applications. My name is Alejandro Martin Gomez from the University of Arkansas, and I will be the session chair. We will have 3 presenters in person, and we have 1 remote presentation, which is going to be the last presentation of the session. And today we are going to welcome Laura Schütz. She's a PhD candidate at the Chair for Computer-Aided Medical Procedures at the Technical University of Munich. And she will be presenting her paper, A Framework for Multimodal Medical Image Interaction.
Hi, my name is Laura Schütz, and on behalf of my co-authors, I'll be presenting our work called A Framework for Multimodal Medical Image Interaction. But before I start, I want to talk a little bit about the motivation behind our work. Augmented reality is about augmenting human senses. But most of the time, the augmentations that we have, they remain unimodal visual. But when we are faced with complex, high-intensity tasks, like we often are in surgery, sensory overload can actually occur. And this is where multimodal interactions can be used to reduce cognitive load and user errors. So let's take a look at the example of brain tumor surgery. Here, for example, we see a surgeon operating on the open brain. So he or she can see the surface of the tissue, but cannot see beyond the surface and see, for example, where the tumor might be. And this is why navigation systems have been introduced to display the location of the tool in relation to the underlying anatomy. But this information presents additional complexity to the task, because this information is spatially located in a different place, so they have to keep looking back and forth, and they have to perform mental mapping in order to see it in the first-person view. So the goal would be to still present this anatomical information to the user, but in a way that is more intuitive. And so this is why we propose the multimodal medical image interaction framework, which allows us to gain audiovisual interactions with any part of the human body. And since the novelty of this framework lies mainly within the audio domain, I will talk about 2 ways that have been used in the past to sonify surgical procedures. The first of them is parameter mapping sonification, which is mostly used. Here, spatial parameters such as the distance between a tool and a target, or the angle of a tool in relation to a target trajectory, are then mapped to sound parameters like the amplitude or the frequency. This method, however, lacks in intuitiveness, because there's no causal relation between the sound that is produced and the actual tool-tissue interactions. But luckily, there's an audio synthesis method called physical modeling synthesis, which allows us to create more realistic sounds. And so here, the sound is simulated by mathematically modeling the physical properties and behaviors of real-world objects to generate sound output. So when we interact with these models, we create vibrations, which are then resulting in resonances that can be captured and recorded as sound. So in our framework, what we essentially do is that now we can take the anatomies and make resonating instruments from the different anatomical structures. Importantly about this is that either when the point of interaction, the physical properties, or the geometry is changed, the resulting sound will change as well. And I have brought some examples to demonstrate this. So here we have the model of a vertebra, which is a bone in the spine. And now if we interact with it in different locations on the model, the sound will change. If we keep the same geometry, for example, here of brain tissue, but we change the elasticity, so the physical value, the sound will also change. And lastly, we see an example here where we take the different geometries of the different vertebrae in the spine, but we keep the physical properties. So we use this physical modeling synthesis method in our framework. To enable this, we first take medical images of the human body. Could be MRI of the brain, CT of the spine, any kind of medical imaging modality. We pair it with the physical properties of the tissue to create 3D models of these anatomical structures. And then, through user interaction with these models, we create vibration and the resulting sound, and the visual rendering of these anatomical structures, together with the sound, then presents audiovisual feedback to the user. And so we wanted to see how generalizable this framework is. So we tested it on different parts of the spine and the brain. So everything from very soft tissue like tumor tissue, brain tumor tissue, to something very hard like bone tissue in the spine. And so now let's have a listen what that sounds like. So now you might have noticed that two of the sounds are very similar. And that's very logical because the white matter and the gray matter in this example, they have very similar geometries and very similar physical properties, so the sounds will be very similar as well. So what we did in these cases is that we transformed and scaled them into an audible perceptible range while still maintaining the central relationship between the values. We then wanted to see, can we use this framework now, and can users actually learn audiovisual correspondences using me? So we gave those 34 participants 2 different question types. We provided them with an audio sample and asked them to choose the corresponding visual from a set of 3, and we gave them in the visual to audio, the visual, and asked them to select the correct audio representation. And what we saw is that there's more correct answers when they were tasked to go from audio to visual, and that the number of structures also impacted the results. When they were given 2 instead of 1, the recognition was higher. So now that we've seen generally that our framework is able to establish these correspondences, we wanted to make it more realistic and apply it to a real medical task. So now the question was, can we have audiovisual interactions that then improve the performance and reduce the cognitive load during medical localization tests? So we tested this with 9 neurosurgeons and neuroradiologists in a virtual reality setting. We gave them 2 conditions, the pure visual and then the audiovisual one. And now I'll show you a video where you first see the training scene where they're still presented with the visual renderings of the structures, and later the testing scene where these are hidden. And so the high-pitched sound that you heard was the tumor. And so we had asked them to, whenever they felt that they had heard the tumor, to place spheres at the margin of the tumor. Then we created a convex hull from these markings and compared it to the ground truth tumor segmentations using the dice coefficient, which is a measure of overlap. And so we saw that there's a significantly improved accuracy when using me, so the audiovisual, over the unimodal visual feedback. We didn't see significant differences in task load or task time, but we did see that multimodal was preferred by all 4 neurosurgeons and 5 neuroradiologists. Now that we've shown that ME has the potential to enhance interaction with medical images in localization tasks, we hope that future research will build upon this and apply it to many different surgeries and parts of the body. If you are looking for more detail, please refer to our paper. Feel free to connect on LinkedIn. And if you have any questions, suggestions, or ideas for me, please approach me after the session or write me an email.
Are there any questions from the audience?
Thank you. Hey, David Lindelbar, Carnegie Mellon. Super cool presentation, very interesting work. So I was wondering if you could talk about the application scenario. If you imagine this to be used in an operating theater, you might not only sonify kind of the brain tissue, or kind of generally the general tissue, but you also might have sonification of other vitals in other parts. So you're creating potentially this super complex sound environment that might actually be distracting. So how do you think should we focus some of the multimodal interactions to say, okay, sometimes I only want to hear the vitals, sometimes I actually do want to focus on the specific task at hand?
Yeah, thank you so much for the question. I think this is where the topic of adaptive user interfaces comes in. So, I mean, when we have a very noisy OR, then of course we need to make sure that there's no overlapping and that there's still saliency of the audio signals so that we can perceive them well. The other thing is that, and it's also research that we've looked into, Sasan, who's also an author on this paper, has looked into, where we can actually record a lot of the sounds spatially actually in the OR, and then see how we can maybe adapt or pitch shift or do some of these things so that it becomes more salient.
Hey, great work, Manuel Rebor, George Washington University. My question is about adding haptic feedback, maybe just like vibration in addition to the audio feedback. Yeah, just thoughts on that. How would you like combine the two? And yeah, any thoughts you had?
Regarding haptic feedback, the thing is that it depends on what kind of surgical task you're looking at, if it's like a very delicate one or if you can apply more force, basically. But in cases like this, where it's very small, delicate instruments and the tissue you're dealing with is also very tiny, I'm not sure that haptic feedback would actually be the best idea because they rely heavily on these very subtle haptic cues that they get from the interaction with the brain tissue. But for example, I know that Alejandro has done some work on haptic feedback for aligning a surgical drill, where there it's not during the actual execution of the surgical task where you might want to have that, feedback, but it's before, during the alignment, where I can imagine that something like this is helpful.
We have time for one extra question.
Thank you. This is Yuxuan from Stanford University Immerse Lab, and Bruce said hi. My question is that I very much believe that using this kind of physical modeling synthesis, you are able to create more intuitive and more natural sound. But do you think it's possible to do some user study to demonstrate that really using this kind of mapping is easier for the users to learn this kind of correspondence rather than using some random parameter mapping?
Yeah, so for example, right when I was explaining between parameter mapping sonification and this, I think that we haven't studied that yet, so it would be very interesting to compare it directly to each other. But from what, my intuition would be that this is a little easier to learn, yeah.
Okay, thank you.
All right, so let's please thank again to our speaker, Laura. Please remember, if you have any more questions, we have our Discord channel, so we will be able to continue the discussion there if you have any more questions. Then let's welcome our second speaker for this session, Minna Dastan. She's a PhD candidate at the Polytechnic University of Bari, and she's going to present today co-designing dynamic mixed reality drill position widgets, a collaborative approach with dentists in a realistic setup.
Okay. Thank you for the kind introduction. Hello, everybody. My name is Minna Dastan. I'm a PhD student at Polytechnic University of Bari, and today I'm excited to present our collaborative research, which was done in collaboration with LMU Hospital and Technical University of Munich. So let's start by addressing a key challenge that dentists, like in other medical fields, often face, which is applying a preoperative plan into surgery. This is challenging since it requires certain dexterity skills from the surgeon, and since the operative area is restricted, visibility is limited, and patient movements really adds to this difficulty. Some potential negative results of the inaccurate drilling can cause implant failure and even long-term complications for the patient. Thanks to mixed reality offers to enhance the precision by reducing the margin of errors using the visual assets that we call them widgets. Our motivation comes from the systematic review that was presented by my tutor on Tuesday here in ISMAR for mixed reality tool to target positioning widgets that shows the potential that this widgets has potential but have some limitations as well for the widget design to use the theories such as Gestalt theory. For those who doesn't know, it's a theory for a perception that forms configuration presents an information for the user, or some methods such as interactive dynamic methods. Other limitations is also the comparison of the standardization and also end-user involvement. In our case, it's the dentists. So our contribution in this paper is co-designing with experts, comparison between static and dynamic widgets in a realistic setup implementation and dentist evaluation and collecting their perspectives. Our co-design methodology focuses on creating end-user-driven systems for measuring the outcomes. We had a group of experts, which were 2 dentists and 3 mixed reality developers. We did several focus groups, demos, and meetings for over 6 months at the LMU Hospital Department of the Dentistry at Munich. So as an outcome of our co-design, we co-designed 4 mixed reality widgets, which was 2 of them inspired by the literature, the static widgets, and the 2 of them was the dynamic widgets. Starting with the static widgets, the first condition we have the entry point, which was unassisted design, requested by the dentist that only had the position information with the static yellow points. And the drill tool had no augmented cues. Instead, the target axis was the literature-inspired baseline. The dentist had the yellow axis to show the position and rotation. And the drill tool additionally had a red circle on the top of the drill tool as a static feedback. So starting with the dynamic widgets, it's based on our previous work. It leverages the Gestalt theory. It consists of 5 graphical pairs, and each pair has an information for the color of the pairs, indicates the axis, while their shape indicates the error components. For the positional error components, we have the 3D V-shape elements. Instead, for the rotational, we have 3D brackets. And finally, their distance indicate the error feedback, which means that whenever the tool is far away from the target, you can see that the pairs are separate from each other, and when the dentist aligns the tool with the target, the pairs gets together. We also introduced the dynamic visibility areas. While the tool is in the maximum threshold is reached, you can see that the pairs are static. And in area 2, pairs become dynamic with nonlinear behavior. And finally, at area 3, you can see that the pairs become invisible when the target threshold is reached. So we combine the dynamic widget with the static widgets. The first condition is the dynamic widget with entry point condition, and the second one is the dynamic widget with target axis combination. As an outcome too, we had a realistic setup in a dental room with a physical phantom, and we did a replica of this dental room in air simulation in VR. The dentist had a right-hand controller flipped to have a real drill tool handling. And for the tool confirmation, we had a foot pedal. And we also introduced the virtual loop as it was requested by the dentists because they are using magnification loops in their clinical settings. So for the research questions, we compared the dynamic widgets performance versus static widgets, and also search for the impact of the time over precision, and further investigate the age and gaming skill influences on the precision, and finally the preference of the dentists. We collected quantitative and qualitative data, and the dentist had the tool alignment task during the user study. Lasted around 45 minutes. The dentist first go through a training phase, and then started the main experiment in a Latin square order for balance comparison, and then they answered the questionnaire, and we did an open interview for the preference. We conducted a within-subject experiment with 35 dentists, with 18 males and 17 females. They came from various backgrounds, from prosthodontology to orthodontology, and had years of experience in dentistry. So for the results of performance comparison between dynamics and static widgets, we see that our first hypothesis is supported. Dynamic widgets significantly improved over static widgets. You can see in the positional y-axis on the left graph, and also in both rotational axes as well. Meanwhile, comparing the two dynamic widgets, we see that dynamic widget with entry point is actually faster than the dynamic widget with target axis. However, they didn't significantly differ in positional or rotational error. And for the entry point condition, we see that our third hypothesis supported is the fastest condition, but it's also the least precise condition. We were expecting this for the rotational magnitude, since the dentist didn't have any rotational cue, but it was also the least precise in positional as well. When comparing the task load of dynamic widgets and static widgets, we see that our fourth hypothesis is supported. Target axis significantly has less task load than the dynamic widgets. And we also see that our fifth hypothesis supported. Dynamic widget with entry point has less mental and physical demand than dynamic widget with target axis. For the correlation comparisons between precision and time, we see that longer task time actually indicates better rotational and positional errors. We find significant correlations for the dynamic widget with entry point, when the dentist that took more time had better rotational error. And for dynamic widget with target axis and target axis conditions, we see that the dentist had better positional error over time. Meanwhile, for the age and gaming skills, we see that our seventh hypothesis is supported. Significant correlations for the dynamic widget target axis. Junior dentists had lower position and rotational error. And we also see that gamer dentists had better rotational magnitude as well. For the dentist opinion, we see there's a mildly preference over dynamic widget with over target axis. The dentist said that positioning along the z-axis, the forward axis, was challenging, and they find that dynamic widget can be a valid solution. However, they said that it requires training. But they also said that it can enhance the precision and their usability if there was more training with the dynamic widgets. For the target axis, they said that it was straightforward, but they find it kind of challenging for the rotations, and for the entry point, it was demanding for the precision. So for the conclusion, we found that co-design is actually a really effective tool for widget design and for the realistic setup. We see that dynamic widgets was the preferred and has the best performing in position and rotational error, but it has a time and task load trade-off. We find negative correlation for the time and errors. Dynamic widget entry point had better rotations, and the other conditions, dynamic widget the target axis and the target axis has better positional error over time. We also find that junior and gamer dentists are better with combined widgets with dynamic widget with target axis as well. And as a future works, we would like to investigate precision maintenance, such as active drilling, to investigate. So here I would like to conclude my presentation. We provided dynamic widgets as an open source to foster future research. I would like to answer your questions. Thank you.
Okay. Question.
Sorry for the far travel. Thank you, Mina, for the interesting presentation. I love your work, also since like what I've seen previously at ISMAR as well. So it's great to see that you're still working on it. I was kind of surprised with the NASA TLX results that the entry point at a very low mental demand compared to all of the other conditions, probably because no instructions and they can just do what they want. But the performance was really like a lot less compared to the other instructions. But it seems that the dentists themselves were like, oh, but it was not hard to do. Did they actually perform like badly in a sense of like, was it actually bad in terms of like dental practices of, oh, the accuracy they achieved is something that dental practices should normally not be allowing, or was it still within like the allowed margins?
I wouldn't say that they didn't care, but having the dynamic widgets, I think they give more attention to use it. Maybe that's why the results for the entry point was a little bit higher in the task load. But I think they give all conditions in the same manner.
All right, thank you.
You're welcome.
Any other question?
Thank you for the interesting talk. So I was wondering if using your application can be applied to augmented reality, because I think your widget has a perfect application in AR, and you can see that
applied in
augmented reality.
Yeah, we would like to, it's also our future direction to have a realistic with all the setups with patients in augmented reality. It's our future direction, so we are thinking to it. We are also open to collaborate, so if you want, we can collaborate and develop it in augmented reality. We are open.
Thank you.
Thank you.
Any more questions? Please, because those were the two questions that I had, actually.
Okay.
So I will try to follow up on that second question. It seems to be like the magnifying loop. It's a very desirable component for the dentist, right?
Yeah.
And thinking about that scenario where you move to augmented reality, have you thought what could be a good way to enable having that magnification?
Yeah, I think it can be great to use the real tools of the dentist, the magnification loops itself. But currently we didn't implement it, but it would be really interesting to use the real magnification loop.
The idea will be to provide the augmentation on that magnification loop, or how would you then show the widgets to the surgeons?
Yeah, I get it. Yeah, it's an interesting question that I haven't think about it.
Yeah, so a quick follow-up question as well, because I saw that you briefly covered it, but maybe in a bit more detail. So you did a lot of dentists in your study, but to what extent were they actually excited to have such instructions in augmented reality potentially? I know that's your next step, but they probably had some point of view of oh, this is something that we actually really want, or maybe not at all. What was your experience?
Sorry, I didn't get. You are saying that they were many dentists from the different backgrounds?
No, I just mean more of as in you did a lot of dentists in your study. So basically, I was just wondering how excited were they for the potential of such instructions for their daily activity?
Yeah, they were really excited. Actually, they had other projects that I can not tell here, but they are excited, and they would like to use this technology in their current, let's say, in the daily surgical operations.
All right, very interesting. Thank you.
Thank you.
All right, so let's thank our speaker again, and let's prepare for our third presentation. Okay, so then let's welcome Ruyun Dai. She recently completed her master's students at the Hanyang University, and she's looking for PhD positions. So if you have anything, she's looking for positions. And today she will be presenting her paper, Virtual Reality Multimodal Stabilization Intervention for COVID-19 Trauma Treatment.
Okay, hello everyone. My name is Ruyun, and it's my honor actually to be the last in-person presenter to this session. And our paper letter is Virtual Reality Multimodal Stabilization Intervention for COVID-19 Trauma Treatment. And let's get started. So firstly, COVID-19 had a serious impact on the public's mental health. Experiencing or witnessing COVID-19 related distress may cause post-traumatic effects, especially on the high-risk groups, including the healthcare workers and COVID-19 survivors. And stabilization is the first phase of the trauma treatment. And stabilization focuses on inducing the positive emotions and enhancing the feelings of safety and control, while reducing the perceived distress and anxiety symptoms. So stabilization intervention usually includes the psychoeducation and various stabilization techniques. And these techniques are typically performed by the therapist narrative instruction, and with guided imagery, which is involved the imagination and body sensations. So to apply the stabilization techniques, National Mental Health Center of Korea developed a mobile application that uses the natural image and narration audio fields to help trauma patients practice the stabilization techniques with their smartphone and without a professional therapist. However, the mobile application has the limitations. Firstly, although the application uses images to guide patients' imagination, it's difficult for patients to immerse themselves in the treatment situation or the environment. Second, the stimulation that patients can image are limited, and the lack of sensory stimulation may affect the vividness of patients' perceptions. Therefore, in this study, we implemented 3 stabilization techniques: light stream, breathing meditation, and containment, with multisensory thermal feedback and the eye tracking interaction. And these techniques are executed in 3 VR environments, including forest, beach, and field. So to the best of our knowledge, this is the first VR intervention study, especially targeting to the stabilization techniques. So therefore, we pose the following 2 research questions. Firstly, does our VR stabilization intervention provide the effective treatment of trauma? And second, is the effect of treatment with VR stabilization intervention superior compared to the mobile app intervention? Okay, next I will briefly introduce our 3 VR stabilization techniques. First, the light stream techniques guide users to image the feeling of the healing head shining on their body, and this technique implemented a virtual avatar body and thermal feedback, which provided by the thermal real device, where we can see wear on their arms, and to replicate the feeling of a warm virtual light stream. Yes. Next is breathing meditation technique. These techniques provide training to enable patients to focus on their breathing, and it gets patients to breathing not requiring any input from patients themselves. And we provide a virtual beach environment with the sound of ocean waves. The sound of ocean waves and 2 virtual elements, which is text and animation, to guide the breathing. Third is containment technique, which containment technique can help users easier and safer to handle the uncontrolled memories. By containing the uncomfortable memories, emotions, thoughts, or feelings to a rich container from which they cannot escape, user can feel a sense of control over the traumatic memories. The existing containment technique in the mobile app intervention is only based on the mental health imagination. However, our VR intervention enables users to virtually observe the virtual portrait containing the uncomfortable memory and observe the box is opening and closing, and clearly hear the box being locked. Okay, this is our 3 VR intervention, and so to evaluate our VR intervention, we designed an experiment that involved total 82 participants, including the healthcare workers and COVID-19 patients, and they are assigned randomly to the experimental group or the control group, and they participate in treatment sessions once a week for 5 weeks. And for measurement, we firstly use the subjective units of distress, which is a self-report questionnaire, and its squares range from 0 square means total relaxation to the 100 square means full panic. And to avoid the limitations of self-report measurement, we also collected the heart rate variability HRV data as an objective measurement. Both the SDN and RMSSD data are the time domain measures of HRV, and the individuals with PTSD post-traumatic stress disorder have the lower level of HRV than the individuals without PTSD. So for the results, in the terms of subjective measures, we firstly compare the SUD scores of VR group during the weekly treatment sessions, during 5 weekly treatment sessions, and we can see the reductions of SUD score in VR group show the significant difference between before and after treatment session. And for the change value of SUD score in the VR and app group between pre and post-intervention, which is pre-intervention is before the first week, and post-intervention is after the final, the 5 weeks treatment session, the decreased value of VR group was significant. The decreased value of VR group was significant difference compared to the app group. And in terms of SDN and RMSSD data of HRV, when comparing the values in pre-intervention conditions, there is no significant difference existed between the VR and app group, which means the baseline conditions of 2 groups are well controlled. While comparing in the post-intervention conditions, the VR group show a more positive effect than app group, that the SDN and RMSD both these 2 data were significantly higher than the app group, which can imply that they reduce the stress level and increase the more relaxation through our VR intervention. Okay, finally, I will summarize our finding based on the result and discuss some implications for designing the VR multimodal intervention. Firstly, our study verifies the treatment effect of VR stabilization intervention. We found that VR could achieve effective treatment with stabilization techniques, and VR group participants experienced significant reductions in subjective discomfort after each treatment session. And next, we compared the VR stabilization intervention with an audio and image-based mobile app intervention. And VR intervention had a more positive impact on participants' subjective discomfort and also the psychological response than the mobile app intervention. And based on our design, we will give some design implications. Firstly, our study is focused on the stabilization, which use the guided imagery therapy. So we can consider about like the specific trauma therapy performed by the guided imagery may benefit more from the VR intervention, because the VR can provide an immersive and realistic experience instead of requiring them to rely on users' imagination and memory. That's what VR can provide. And next, in this study, we use the multimodal, which is one of the multi-sensory is thermal feedback, and thermal stimulation provided in VR has been limited explored in the field of psychotherapy. And in this study, we demonstrate the potential value of thermal stimulation as a symbol of the vivid imagery and positive emotions in VR psychotherapy. And next is virtual interaction and guided elements can enhance the positive emotions when participating in treatment session. And in this study, our VR interventions compared to the mobile app, we add the more interactive guidance elements, and it can support practice more suited to the focusing on the present moment from an attention-enhanced perspective. And lastly, in addition, it is noteworthy that individual difference exists in users' thermal experience, and this difference may be attributable to the skin-sensitive and personal experience and environmental factors. And that's how, if you are interested to our study, please refer to our full paper. Thank you.
Okay, thank you very much. Do we have any questions in the audience?
Yes, thank you for your presentation, even though the COVID-19 seems so far away from us. Yeah, so we have a really simple question that we mentioned that you noticed several treatment techniques in your presentation,
yes.
But we want to ask that why you choose those 3 specific techniques but not the others.
Yes, that's a good question. Actually, there, like I mentioned before, there are various stabilization techniques for this therapy, but why we choose these 3 techniques, because actually there are different types of the stabilization method, and some of them using the directly stimulation, like the light stream techniques, and another techniques maybe need the directly interaction or the actions. So that kind of techniques, it has limited explore in the app or another image or audio-based intervention. So we choose these 3 techniques, and it can balance the stimulation or action interaction techniques. So that's the reason why we choose these 3 techniques.
So you have almost answered my question. The first one and second one I fully understood. Can you tell us a little bit about the third experiment? I didn't fully understand what was the purpose for the third one with the box and with the closing of the box.
Yes, you mean the containment techniques?
Yes. Just if you can tell us a little bit the be objective and the process, because I didn't get it fully. For the first two, it was clear for me. The third one was not.
I'm sorry, I didn't.
No, can you explain again the third one?
So first, we choose those techniques because we collaborated with the actual hospitals and then medical psychologists. And then for third one is containment treatment. And then for mobile app, which was provided by our government, they just give like a textual instructions. So patients, they should imagine themselves by reading the text. But in our case, we provide some intentions. So participants or patients, they can actually choose their bad memory and then they can draw onto the frame. And then using controller, they put the frame into the box and then they can lock the box. Also, we provide some kind of personalizations for each patient, so they can choose among 8 available boxes, whatever they want, they can choose that one. But we do not show in this video, but so that way, patient maybe can more effect from those treatment. So easy answer for your question?
Just for the sake of time, maybe we keep that discussion offline, right? Because we have one extra presentation and we're kind of running out of time. So let's thank again our presenter. Our last presenter for this session is a remote presentation. So would it be possible to switch? Okay. So then let's welcome Hamraj Jahaveri. She comes from the German Research Center for Artificial Intelligence, and she will be presenting design and clinical evaluation of ARAS, an augmented reality assistance system for open pancreatic surgery.
Hi everyone, my name is Hamraj Jahaveri. I'm from German Research Center for Artificial Intelligence. Currently I'm in Melbourne, that's why sadly I cannot participate to the conference. I'll be presenting our work about ARAS, our designed augmented reality assistance system for open pancreatic surgery. First, I would like to actually talk about why there is an essential need for assistant and navigation system in general for open abdominal surgery. So from the left side to the right side, you see the images from the operation field, the left side being the beginning of the surgery and the most right side being at the resection phase. So these photos are captured from the surgeon's perspective. And the short message here is what you try to see in the first picture at the beginning of the surgery is the surgeons not being able to actually visualize any important vascular system or any essential structures that is associated with that type of operation. And as the procedure progressed, so they try to prepare this vascular system and prepare it for the resection phase so they can remove the tumor. And while doing those stuff, they try to not damage any structure that is vital to the patient so that could actually have a fatal result for the patient. So in a conventional setup, that the surgeons actually have sort of assistance from the data that's captured from preoperatively or an assistant from the intraoperative capturing devices like an ultrasound. And what they try to do is actually try to merge all of this information through a cognitive aligning process with what they see and observe during the surgery and try to figure out where those important vessels are. So try to not damage them while trying to resect and remove the tumor. So now you kind of have the feeling why it's really important to have some sort of navigation system to try to avoid unintentional damages to the vital structures. But so the question is, why hasn't much been done yet in the abdominal surgery? So the short answer to that is the organ deformations. And what I mean by that is, so you have some data preoperatively captured about the patients through the CT or MRI or various ways. And you have this data, but what happens during the surgery is once you open the abdomen area, there are some shift and deformations through the organ, which actually reduce the validity of the preoperative data. This type of organ deformations is substantially observed during for example, mostly during the surgeries associated with the liver. But that's why all of the works that try to use the AR or some sort of navigation system that uses or relies on the preoperative data kind of has these challenges that you cannot use those data anymore during the surgery because of the organ deformations. So, but unlike organs like liver that's like substantially changed and deformed during the surgery, there are some abdominal organs that has lesser deformations like pancreas. So because it's actually behind the stomach and it's just buried in the abdominal cavity, so it does not move as much as the liver do, and it's also the texture is quite different than liver, so the deformation is quite less. But despite that, there is not actually much done in this area. So in the literature, we saw some works actually done, and so there are two types of the works that's done in this area. The first is actually non-in situ visualization of the 3D models reconstructed from the preoperative data. And so they place this 3D model around the patients and try to create a special awareness that where those structures might be based on what they are observing. And there are also some in situ visualization that they use tablets and marker-based trackings. So the challenges with these methods are, for the non-in situ is frankly not quite different than having the CT scans during the operation, because it's again this cognitive alignment process associated with this type of visualization. And for in situ visualization, so far only tablet-based visualizations have been tried. And the issue with them is, so the surgeons need their hands to do the operation. So, and because they do need their hands, they cannot use the tablets continuously throughout the surgery. So it's not that much of different than having an ultrasound assistant during the surgery. So that's why it's not really commonly used so far. So what we did in our study is we defined two main research questions. So we wanted to know that what is the requirement and the features that an AR assistant system should have for open pancreatic surgery from the surgeon's perspective. And once the design system is finished and we develop the system, actually how it performs in the end user setup, because in such critical domain, you cannot just go and rely on the simulations. And frankly, there are many situations that you cannot simulate and go otherwise during the actual surgery. So it's really important to trying to understand how your system performs during the actual setup. So we designed a study procedure that we actually have the involvement of the surgeons throughout the study, and iteratively refining the system and testing the system while collecting the multiple data. I'll just go ahead and quickly give you an overview of each stage. So in the pre-design stage, we collected questionnaires and interviews from the surgeons, trying to more of understanding what's the needs and what's the requirement for such system. So we collected the questionnaire data on what is the need and when that need is most important. So what we observed from the questionnaire result was there is a substantial need for AR assistant, or rather navigation assistant, especially during the initial phases of the surgery, because as you saw in the previous slides, the surgeons practically don't see anything. And this is more important to have the navigational assistant where they don't see, so they avoid damaging the vascular system, where in the later phases of the surgery, they actually see the vascular system. So it's not that much of important. It's still critical to have some sort of navigation, but it's not as much as important or critical to have those navigations, because they technically see what's there and not damage it. So we defined some design requirements based on our interviews and the questionnaires, which involved having a robust, accurate system which is intuitive to use and would robustly work under the surgical environment, and also sort of provide the venue to use the integrated data access of the patient, because the surgeons are used to, use all of this information from preoperative data, including the patient history and the CTs and all of those images, and try to make a decision based on those during the surgery. So after we defined these rules, we actually developed our system and iteratively refined it with the surgeons, making sure that it works as it's supposed to, and the surgeon thinks that it's useful to have it. And what the system consists is actually we try to focus on the in situ visualization of the 3D model, which we reconstructed from the CT images from the previous preoperative data. And we also focused on the intuitiveness of the user interface, because we don't want to add any extra cognitive load on the surgeons, as they already have enough. So for the in situ visualization, we use the marker-based approach, and for the non-in situ supportive data visualization, we actually use an approach that the surgeon could place them anywhere in the surgical room. So what we did for the marker-based tracking was we tried different types of markers under different types of the light conditions, because it was a big challenge to have an accurate system that works reliably under different environmental challenges of the surgical room, which one of them is actually the surgical light, because they are so intense that many trackings actually don't work. And we saw that, like, if we 3D print a marker, it's easy to sterilize it. It could be used during the surgery within the operation field area, so they could reliably use it without worrying about the sterilization issue, and also it's reliably working under lighting conditions. So for the placement marker, and unlike previous works where they place the marker directly on top of the tracked organ, we actually put it outside of the operation field on the sternum, because all of our focus was trying to provide a way that we could actually continuously use the AR navigation support. And after discussion with the surgeons, we observed that the sternum remains in a constant relationship with the tract vascular system and the pancreas. That's why we chose the end of the sternum for the marker placement. So for the intuitive user interface, actually, as I said before, the surgeons need their hands, and all of these hand gestures are not quite common for the surgeons to use, and there is a learning curve associated to using hand gestures, and also they need their hands, so we opted for a fully voice-controlled user interface. What we did is to ease this memorization of the voice control commands. We used the terminology from the medical domain. These are the keyboards that they actually use in a regular basis throughout the surgery, so it would not actually cause them any memorization issue when they use the system. So after we developed our prototype, we go and started the clinical trials. During the clinical trials, we actually tested our system during the actual surgeries. The procedure consisted in each surgery, started with the placement of the marker in the sternum, which is done by a surgeon, and then moving ahead and try to observe the structures, and as the procedure progressed, so they actually evaluate the accuracy of the system using an ultrasound device, which is a real-time intraoperative device that they commonly use. So our study included 7 patients with 3 different types of the operation, which really helped us to evaluate the system throughout different operation types. And what we observed was the surgeries usually lasted about 260 minutes, and the system was used for more or less half of the surgery. So this is actually in line with our pre-designed questionnaire, where they defined the need of the navigation system more in the initial phases of the surgery and not after resection, because they already see the important structures afterward. And also what we observed from the questionnaires that we made for accuracy measurements, which we collected immediately after each procedure, was while the arteries and veins accuracy quite high during the initial phase of the pre-resection and resection phase, the tumor is less accurate, but still accurate enough for them to try to understand the whereabouts of the tumor. And after resection, because there are so many manipulations and deformations, the accuracy actually drops, which is kind of expected results. So we also used with the surgeons. So what we observed was that the system was quite appreciated by the surgeons and helped them actually to navigate the surgery better. And there are some technical reliability and improvement issues associated with the marker placement, because on some very rare occasional cases that the surgeons had to pull up the sternum to make more space for the operation in the abdominal cavity, and therefore it caused the loss of the predefined relation between sternum and the tract structures. Generally, they didn't have any issues considering the ergonomics of the device that we used. We used HoloLens 2. But what we also observed was the system was quite more appreciated by the junior surgeons, and they actually mentioned it that because it helped them to understand the procedure quite better, because they don't have as much experience as the lead surgeon does. So it was quite helpful for them to understand the procedure. And by that, I would like to finish my presentation. I hope I didn't get much of your time. We were on the news for the Deutsche Welle. Feel free to scan the QR codes about our project if you're interested more, and I'll be happy to get any questions. Thank you.
Okay, so we'll have time for one, maybe two questions. Hamras, are you able to hear us? Can we switch to the Zoom view, please?
I can hear you. I hope you can hear me too.
We can hear you, yes. So we have the first question for you.
Thank you for this presentation. Really interesting work. Maybe I'm not understanding the engineering aspect of ERAS very well. How is one marker potentially sufficient for accurate position and orientation tracking of those blood vessels? Because they can be in different positions. They can be in different pose relative to that marker in each and every individual.
So maybe I answer this. So when we 3D reconstructed the vascular system from the CT images, most of the important vascular systems are actually behind the pancreas. And in the operation, the first stage is to actually try to reach them, so they remain stable. That's where the priorization and resection phase, where our system was accurate. And after they reach those vascular system and try to manipulate it or cut it in some ways, then the system accuracy drops. So that's why the relation between those structures actually don't change, and we were able to actually use a single marker for correctly project all of those vascular systems. I hope that answers.
I'll just do a pretty quick follow-up because I have the same question, because this anatomy seems to be also deformable, right? So the placement of the marker on a rigid body, would that solve the problem of the deformation of your anatomy?
No, that's something else to discover, I guess. So this is something that we are currently working on. So our system has some limitations because we're still relying on the corroborated data. But as I said in the beginning of the presentation, pancreas has less deformation compared to other abdominal organs. That's why we were investigating whether we can actually use the corroborated data still to some sort of provide the navigation, because in a conventional way they still highly rely on the corroborated data such as CT, and they still try to observe those vascular systems during the surgery, because there is no other better option yet. So even though they use ultrasound, so the ultrasound still shows some, you can use the Doppler or you can use the images to track the vascular system, but it's not as accurate as the CT to show you those vascular systems. So they still rely on those corroborated data. In this study, what we were trying to do is whether we can actually use this data, and if we do, until when we can rely on those corroborated data. So in our current project, we are trying to solve this issue of finding some real-time data to somehow have this full-time coverage of the navigation for the surgeons. But as I said, so the first initial stages were more important to them, and I think at least speaking for the pancreas, we were able to actually help them by using the corroborated data until the resection phase.
I think as a follow-up to the two previous questions and to your answer, I think it's important to consider it. I mean, often in surgery, people ask the question, is it good enough? Is the registration, the accuracy good enough? I think it's important to consider, what is the alternative? What are they using today? And are you improving upon what they do today? Right, and I think in this case, that's a clear demonstration that they are. But also on that topic, I wonder have you considered registration with the spine, if that's less mobile, like a fiducial on the back or the table or something like that?
So choosing the sternum in our upcoming study that is currently under submission, so we have a second mark. So we didn't rely on the first marker because, as I said, sternum has some limitations. But the reason that mainly we opted for the sternum was like we were trying to also compensate the breathing motion that heavily moves everything with it. That's why we used sternum and not any other bones compared our patients with the previously operated patients that we didn't use our system, and we found out that the operation time was around 15 minutes less when they used our system, and also the bleeding was significantly less, and the hospitalization was also less, and the tumor margin was 0 when they used our system. So these are the results that shows that the system is useful.
Okay.
And the accuracy is, we don't have a metric unit here, and we only rely on their judgment of whether that's accurate or not, because there's no way of actually measuring how accurate this was during the actual surgery. I mean, at least not currently, there is any method that you could somehow measure it. And all of those structures are behind some tissues, so we relied on their judgment of saying that yes, that was there. And if you read our paper,
Okay, I'm so sorry, but I think I've just, for the sake of time, I'll cut you out there because we have the closing ceremony. I'm assuming they will use. So we can continue the discussion on Discord. I have a few questions that I will post for you there too. So if you have any questions for any of the presenters, just feel free to continue that discussion on Discord.